Hi, my name is Julie Kirk. I'm a professor in the Department of Family and Community Medicine at Wake Forest School of Medicine. Our objective today is to review non-opioid medication option for use in pain treatment. Let's start. Adjuvant analgesics are drugs with primary indications that are non-analgesic in nature, but have analgesic activity in some painful conditions. They're often used as first-line agents for neuropathic pain especially. There's different classes, including our antidepressants, anticonvulsants, and some topical agents. Most of the drugs talked about on the next several slides rank into the Beers criteria, where we have to use caution or avoid use as potentially inappropriate in older adults. Tricyclic antidepressants are drugs that have been around for many years. Amitriptyline is very common, and it's used in very low doses of just 10 milligrams in the evening. By using it at night, it allows people to sleep. One of the side effects is drowsiness, and you can get around some of those side effects while they're sleeping, but they may still have anticholinergic side effects, including dry mouth and urinary retention. And this goes for all of the drugs in this class. The active metabolite of amitriptyline is nortriptyline. So in the liver, it's converted to nortriptyline. And so for some patients, they actually do better on the active metabolite because the drug doesn't stick around as long. So that's an alternative. Desipramine is the active metabolite of imipramine. It's a secondary amine, and that can be used as well. The selective norepinephrine reuptake inhibitors are also used for pain. These drugs are especially unique in the fact that they're also approved for other indications, and so you can use them in multiple disorders. For example, duloxetine is approved for generalized anxiety disorder, major depressive disorder, fibromyalgia, diabetic peripheral neuropathy, and musculoskeletal pain. We have to be careful about not using it if the creatinine clearance is less than 30 mils per minute. And for pain, we usually start at the lowest dose possible because we need to be cautionary of nausea, dry mouth, somnolence, fatigue, constipation, sweating, and loss of appetite that can occur with this agent. Venlafaxine is also approved for depression. It's available generically in an immediate release. And the nausea can be a little more profound with the immediate release. Sometimes we use it in combination with gabapentin for a better result. So each of these drugs can be used in combination with other medications for pain control. Gabapentin has been around for many years and has a wide dosing range. As little as 100 milligrams in the evening can help with neuropathic pain. Many patients, though, will need higher doses. The max dose is 1,200 milligrams 3 times a day. With higher doses, side effects intensify. So the risk of especially drowsiness, dizziness, goes up with increased dosage. Gabapentin, when used with morphine, can increase the blood levels of gabapentin. So that's a drug-drug interaction. And hopefully we're using gabapentin alone and not with an opioid. Sometimes, though, people lose the effectiveness of gabapentin. And in cases, you can try pregabalin or Lyrica. It's a Schedule 5 drug and is FDA approved for the treatment of diabetic neuropathic pain, in addition to postherpetic neuralgia. It can include side effects such as dizziness, somnolence, and weight gain. We have to adjust the dose for creatinine clearance of less than 60 mils per minute. And both of these GABA analogs can be useful for pain control. Gabapentin is being evaluated to move to a scheduled drug, but currently, in 2018, it is still a non-scheduled agent. Other non-opioid options that can be used for pain control include tramadol or Ultram, commonly used for dental pain, chronic pain, acute pain, but it's not really considered first line. It can interact with SSRIs, SNRIs, or tricyclic antidepressants to increase the risk for serotonin syndrome. Side effects include dizziness, headache, somnolence, constipation, nausea, and dry mouth or xerostomia. Now, those aren't all the side effects. I haven't listed all the side effects of each drug I've gone over, but more the common side effects. Some providers are concerned about tramadol causing a dependency in patients, and once they get on it, it's very difficult to get them off of it. Topical alternatives are nice to consider because they don't have to go through metabolism in the body or excretion. So they're used locally, and one of the most common ones is capsaicin. Capsaicin comes in a variety of formulations of topical nature and branded under about 10 different names. It can cause some redness and burning and pain when you first apply it, and especially if there's any contact with hot weather or warm or hot water, it can intensify this effect. It acts through substance P that is thought to be a principal chemical mediator of pain impulses from the periphery to the central nervous system. In addition, substance P has been shown to be released into joint tissue, where it actually activates inflammatory intermediates that are involved with the development of arthritis and other pain triggers. So this can be a very effective therapy for some patients. Topical non-steroidal anti-inflammatory drugs include diclofenac. This comes as Voltaren 1% gel, but some compound pharmacies also make up different combinations of topical pain treatments, so don't rule that out as a possibility. It's good for localized pain, again, low risk for side effects, can be expensive though. I've given you the dosage range for a single joint of the upper extremity, lower extremity, or a max dose if used over all affected joints. Our next category of drugs are the skeletal muscle relaxants. Cyclobenzaprine, or Flexeril, is well known and has been around for many years. Comes in a 5 and 10 milligram and can be very sedating. So we need to be very careful with this drug when people are operating heavy equipment. It's actually got a tricyclic antidepressant structure. It has anticholinergic effects, so we got to caution in older adults when used. Methocarbamol, or Robaxin, has been around for many years as well. It too has a Beers criteria to avoid or use with caution in older adults, and for some older adults it's inappropriate. It's sometimes used in opioid withdrawal. It's got a neurological side effect to include many of the same things we've been hearing with the other agents: dizziness, headache, lightheadedness, somnolence. And we usually start at half or less of the recommended dose that's prescribed. There are several muscle relaxants that are less commonly used, and I would pay particular attention that we should avoid these in our older patients. Carisoprodol or Soma, Paraffin Forte, Scalaxin, Norflex or Nergesic. All of these different agents have a variety of side effects, some severe, and I think this is why you probably don't see these commonly used, but I've just included it for comprehensiveness. Alpha-2 agents such as clonidine or Xanaflax are also used to help with pain. You can see the dosages here for clonidine. Start low, and again appreciate the plethora of side effects, especially somnolence and dry mouth. Xanaflex can be fairly expensive, but also can be used. It has quite a few side effects. The sedation with Xanaflex is even higher than some of the other agents I've gone over today, and a rare risk of hepatotoxicity. So selected NSAIDs for acute and chronic pain come in a variety of shapes, sizes, and colors, and formulations. All available over the counter, and some as prescription. And I think we just have to be cautionary with long-term use of these agents because they do impact the kidney and they are metabolized and they can have an effect on blood pressure. So most physicians try to avoid chronic use of NSAIDs. Think about the topical options for NSAIDs that I went over earlier. Some of the other longer acting non-steroidal anti-inflammatory drugs are also shown here in this slide and can be used for the treatment of pain at varying doses. Our COX-2 inhibitors fell out of favor for a while because of their side effect profile with relationship to cardiovascular disease. So we're cautionary to use these carefully. Celecoxib, Celebrex, and some of the other NSAIDs that demonstrate more COX-2 selective activity are included on this slide. It's important to monitor for adverse effects when using systemic non-steroidal anti-inflammatory drugs. They can affect the platelets, increase bleeding, bruising, can cause GI irritation, and we're especially careful if people have a history of GI bleeds. Plenty of data about the cardiac toxicity related to these agents, and of course what I mentioned with the effects on the kidney with renal function changes. Actually inhibits protective prostaglandins in the kidney, but can also decrease urine output, increase serum creatinine, and cause edema and elevate blood pressure. So careful with chronic use of NSAIDs. Topical NSAIDs should be considered for many patients because they're very low systemic absorption. Several examples of diclofenac preparations are available, including gel, patch, and topical solution. The cost associated with all of these different formulations tend to be very high and require sometimes a prior authorization if the insurance covers it. Acetaminophen is a well-known analgesic. We're not really sure how acetaminophen actually works in the body. It may be a COX inhibitor or even work through cannabinoid receptors. But in general, it's commonly used for mild to moderate pain and tends to be the first-line choice for osteoarthritis. We oftentimes use it in combination with opioids, and there is some risk for hepatotoxicity, so we tell patients to avoid concomitant alcohol use, and we worry about inadvertent overdose with multiple acetaminophen-containing products, and in rare cases it can cause renal injury. So for most adults, if they're chronically using it, we really don't want to exceed more than about 2 to 3 grams a day. The doses vary though for acute pain, and we tend to use higher doses. The data for post-operative pain shows that, especially for example third molar extraction, when acetaminophen is combined with an NSAID such as ibuprofen in doses of about 1,000 milligrams, but some studies use lower doses of 500, that pain relief was comparable to that of an opioid. The National Safety Council outlines the evidence for efficacy of pain medications with a strong recommendation for combination use of NSAIDs and acetaminophen. So overall, there's newer literature that supports the efficacy and safety with the short-term use of NSAIDs and acetaminophen, and specifically a large amount of the recommendations and studies come from ibuprofen 400 milligrams with 1,000 milligrams of acetaminophen every 6 hours, used in combination for up to 5 days. There are several over-the-counter topical agents available for pain relief containing menthol or trolamine salicylates, coming in creams, gels, patches, or sprays. Rubefactants are also available, and they're known as counter irritants because they cause redness in the skin, and this is due to increased blood flow to the area that's thought to help with pain control. There's minimal systemic absorption, and they're often combined with menthol or other agents such as capsaicin. Lidocaine is also available over the counter in a 4% patch branded as Solanopas. Lidocaine is a local anesthetic that works to block nerves from sending pain signals. It's also available in popular products such as Icy Hot, Aspercream, and others. Overall, these agents may provide some relief and are generally regarded as safe. Other options to consider for pain control include some of the earlier lectures discussing OMT, acupuncture, and referring patients to physical therapy, encouraging them to be involved and engage in meditation sessions, yoga, healing touch programs, hypnosis, regular exercise in a variety of forms, swimming, non-weight bearing, and CBT, or cognitive behavioral therapy. These options in combination here or with pharmacologic therapies give the practitioner several choices that can be non-opioid for pain treatment. So overall, we've reviewed many non-opioid options that have efficacy for the treatment of pain. We need to be mindful of potential drug interactions and side effects that will require diligent choosing of the best pain control for each patient, depending on their liver, renal function, side effect profile, and cost. Combination options should be considered with non-medication choices incorporated into a patient's regimen. Thank you very much for listening to this lecture.